the topic. So welcome. Today I will be talking about a non-steroidal mineralocorticoid antagonist, that is Finerenone, which is a new molecule that has now come up. And let me tell you, it has a lot of role as a disease-modifying therapy for both heart and kidney protection. So I, Dr. Singh Sachdev, who is currently working as Director and Senior Consultant on Nephrology and Renal Transplantation.
Sudeep, can you come there please?
Sir, वो हो नहीं पाएगा. It's not possible because.
Never mind this slide. You can.
It won't. I won't be able to change it. Okay, that's why I'm just sitting here.
Okay, go ahead.
So what are the meeting objectives for today? I'll be talking about type 2 diabetes mellitus with diabetic nephropathy, that is a chronic kidney disease secondary to diabetes, understanding the journey for a patient of CKD with type 2 diabetes mellitus and the typical time points at which new therapies can be initiated in diabetic practice. What are the Finerenone study data, the interpretation and the insights, and to gain insight on the Finerenone clinical evidence and its implication in real life, and integration of Finerenone to, that is to identify the potential patients who could benefit from the treatment of this molecule and its place in the therapy of diabetic nephropathy, both in terms of cardiac protection as well as kidney protection, that is renal protection. So just a particular line that what is the status of Finerenone in India? It is the same as that for US FDA, and it is indicated in adult patients with chronic kidney disease which are associated with type 2 diabetes to reduce the risk of a sustained eGFR decline, that is to delay the progression of diabetic nephropathy, to prevent end-stage renal disease, that is to prevent the number of years one takes to achieve ESRD, to reduce not only cardiovascular morbidity but also mortality, which includes non-fatal MIs and hospitalization for heart failure. So CKD in type 2 diabetes, how urgently do we heed the call for management? So let's take up this case. It's an ordinary case that presents to the OPD, and quite often we see this case maybe on a daily scenario. Raj, name has been changed, a 57-year-old male who presents with type 2 diabetes mellitus in your clinic for a routine checkup. His HbA1c and blood pressures are relatively well controlled. Aside from the usual ailments, the clinical symptomatology of the patient is, he says that I feel good and I hope to stay like this for many years to come. So CKD, as you know, in the early stage has non-specific symptoms which are often confused with alternative pathologies, so he doesn't present with many symptoms. So he has a history of type 2 diabetes for around 10 to 12 years, and HbA1c is relatively, I'd say, well controlled, 7.4%, and he has a blood pressure at the time of presentation of 138/84. So when he presents to us at this stage, I as a nephrologist, if I make a graph in my mind, this is the Kidiko graph for the different stages of chronic kidney disease from stage 1 to stage 5. So in this we can see that in terms of GFR, estimated GFR of this patient in terms of his creatinine comes out to be 61 ml per minute per meter square, and I have not added albuminuria right now. So just on the basis of GFR, he is in that green zone, which is, he has only a mild increased risk of progression of chronic kidney disease. But is this the true picture? That's the question. So as we know, as the disease advances, so does the cardiovascular risk of various cardiac morbidity and mortality. So this guy has a BMI of 34 kg per meter square, so he has metabolic syndrome, and his estimated GFR as per calculated is 61 ml per minute per 1.73 meter square by CKD EPI formula. So in a typical patient like this, the risk of chronic kidney disease progression is underestimated when eGFR is taken alone. So it is extremely important that we take albuminuria along with this, and his urine albumin creatinine ratio came out to be 852 milligram per gram. And if I consider this, that is, if you see the albuminuria column, this falls under severely increased A3 category. So if now I see what is the rate of progression of the disease, this will be a relatively high risk of progression of chronic kidney disease if this proteinuria is allowed to proceed uninhibited and no other newer drug or older drug is added to reduce this. So based on Raj's eGFR and urinary albumin creatinine ratio, the guidelines say that now he should be screened more often, even though he has a near normal creatinine, that is at least biannually, but we'd like to screen him maybe even more often depending on how he responds to our treatment. So this is a slide which presents very beautifully the pathophysiology of diabetic nephropathy. So the first stage is the preclinical stage, which is the stage of hyperfiltration. As you can see, in the early stages, the GFR actually goes up and goes up from the normal 80-90 to maybe 130-140. And as the disease progresses, we enter the stage of incipient diabetic kidney disease where microalbuminuria and hypertension tend to come in. And if that is allowed to proceed uninhibited, this in turn leads to overt diabetic kidney disease, which presents as albuminuria and nephrotic syndrome in certain cases. And thereafter, the GFR goes on declining, the creatinine goes on rising, and the patient reaches end-stage kidney disease. So here, you must understand one thing, that chronic kidney disease by definition is classified as whether there is a renal abnormality, whether a lab abnormality or a rise in creatinine or clinical symptoms for a period of more than 3 months. So the kidney fibrosis actually starts to set in at a very early stage, that is in the preclinical stage of hyperfiltration. So if the patient is in that stage of hyperfiltration for a few months to up to 1 year or maybe even 2 years, the fibrosis has already started. But at this stage, the creatinine will never rise. So first, the renal functional reserve of the patient, which is the excessive kidney function, which one can utilize in when one is exposed to stressful stimuli, goes, followed by an advance of the albumin creatinine ratio or proteinuria, and followed by a rise of serum creatinine. So always don't get fooled by the creatinine of a patient. By the time your creatinine actually starts to rise, that is, I would say with a value of more than 1.1, there has already been a 30% loss, at least a 30% loss of the kidney function. That is the renal functional reserve with which the patient presents. And that is why as the creatinine goes on rising, the rate of progression of the disease is fast. So if I were to quantify that at what level does the risk of all-cause mortality or cardiovascular mortality or even a renal endpoint increases, then you would be surprised to know that when a GFR falls from 75 ml per minute per meter square, there is a gradual exponential increase in the cardiovascular and all-cause mortality. And if we were to pinpoint in terms of the albumin creatinine ratio, even more than 30 milligram per gram, which we classify as microalbuminuria, that is 30 to 300, there is an increase in all-cause as well as the cardiovascular mortality in CKD. So the guidelines recommend that both estimated GFR and albumin creatinine ratio testing at least annually or biannually in patients with type 2 diabetes. And EGFR, as we know, measures the kidney function, albumin creatinine ratio measures the kidney damage, and the recommended guidelines, whether it is the ADA, KDIGO or ACE guidelines, they recommend that both EGFR and urinary ACR are probably used to identify, stage, monitor chronic kidney disease patients in diabetes, especially in the early stage of chronic kidney disease when the EGFR has not gone down, but the albumin creatinine ratio is high, which is how the pathophysiology of diabetic nephropathy works. And we support the routine EGFR and albuminuria to also assess the cardiovascular risk. So both these important numerals or numericals are important even to judge the risk of progression of cardiovascular disease, which is one of the most common causes of mortality and morbidity in CKD with type 2 diabetes. So based on the current diagnosis, this is the medications that he was prescribed. He had CKD for 5 years, type 2 diabetes for 10 to 12 years, and now the HbA1c on the follow-up visit was 9%, blood pressure was still stable. He has metabolic syndrome. He also has a history of hypothyroidism and coronary artery disease. His EGFR is 61 ml per minute per meter square, and an albumin creatinine ratio is 852 and a potassium of 4.9. So this is what I would have done maybe 3 years back. I would have started him on an ACE inhibitor ARB. I would have seen the heart rate and his cardiac risk factors like CAD and started him on a beta blocker. If the proteinuria was uncontrolled, I would have gone on to newer molecules like SGLT2 inhibitors, which is dapagliflozin or empagliflozin, along with molecules to control diabetes, that is biguanides. Dyslipidemia, I would start a statin also because of the pleiotropic and antioxidant effects. And seeing that if the proteinuria is high and he has a high risk for future stroke and he's already a coronary artery disease patient, newer oral onset anticoagulants. So on this medication, if the patient still has an albumin creatinine ratio of 852 milligram per gram, so the question is, do you think Raj is still well protected for cardiorenal progression? That is the question. At an near normal or almost normal GFR. So this slide is a very beautiful representation of the fact that in spite the RAS blockade SGLT2 inhibitors, patients with type 2 diabetes and chronic kidney disease are still at a high risk of chronic kidney disease progression if the albuminuria is still persisting. So these are the various trials, and I'm sure everyone knows about the renal trial when losartan was found to be significantly better than placebo for a composite endpoint of end-stage renal disease or doubling of creatinine and albuminuria. And similarly, these are the trials, that Credence trial which compared canagliflozin plus ACE-ARB versus placebo plus ACE-ARB for both renal and cardiovascular standpoints, and the DAPA-CKD which compared dapagliflozin versus placebo in cases of cardiovascular morbidity and endpoints, and empagliflozin, which all definitively prove that they are highly significant in delaying the progression of the disease by reducing proteinuria and do have their cardiovascular benefits. So they act hemodynamically as well as on the metabolic control. But the question is, we all know the SGLT2 inhibitors have their own piece of side effects, and some patients are not suitable for them. But in spite of giving a patient RAS blockade with SGLT2 inhibitors, do we have other molecules which we can initiate in diabetic nephropathy with proteinuria, with which we can actually reduce the progression of the disease? So the holistic treatment approach of CKD involves different pathways to slow the progression of heart and kidney disease. We have the RAS blockers, and we know how it acts. We have the SGLT2 inhibitors, which has excellent anti-inflammatory, anti-fibrotic effects. It increases the efferent arterial tone and the PG feedback, and it decreases proteinuria, hyperfiltration and oxidative stress. So to prevent the damage on the heart and the kidney, we need to act on the hemodynamic perturbations with RAS blockers, metabolic dysregulation of not only controlling the diabetes but also the other effects of SGLT2 inhibitors, which in turn reduces inflammation and fibrosis, because the key is fibrosis, and once the fibrosis sets in, it is permanent, progressive and irreversible. The only way of identifying the percentage of fibrosis is with a gold standard, that is the kidney biopsy, creatinine, albumin creatinine ratio, ultrasounds. These are all let me say a shadow or pale markers of what the actual damage the kidney is undergoing. So coming to Finerenone, this decreases inflammation, fibrosis, endothelial dysfunction, helps in tissue remodeling and reduction of proteinuria. Apart from that, we do have GLP-1 receptor agonists, which are there for the metabolic control in decreasing weight, dyslipidemia, oxidative stress and even endothelial dysfunction. So Finerenone, how does it act? The mechanism of action. It targets the mineralocorticoid receptor overactivation, which is a leading cause of inflammation and fibrosis, thus slowing both the heart and the kidney disease progression in patients with type 2 diabetes. So the stresses on the body include hyperglycemia, high salt load, oxidative stress, and here is the molecule Finerenone, which acts on the mineralocorticoid receptor and it blocks the overactivation of this receptor and leads to homeostatic action, which in turn prevents inflammation, fibrosis, also helps to help in controlling the blood pressure, causing a fall in the blood pressure, which is further helpful, and it also drives certain metabolic factors which lead to heart and kidney protection. So how is it different from the other molecules that we know, like spironolactone, eplerenone, which we already have been using for a long time? This is a bulky molecule. It is non-steroidal. It is highly selective for the mineralocorticoid receptor. It has an extremely high potency for the mineralocorticoid receptor. It has relatively fewer CNS penetration and sexual side effects. It has a small half-life and it has a tissue distribution of 1:1 and is the only recommended molecule in type 2 diabetes with diabetic nephropathy or chronic kidney disease. While eplerenone we know has been used for resistant hypertension, heart failure with an ejection fraction of less than 30 to 40%, and spironolactone, which has been used as a potassium sparing diuretic for congestive heart failure and resistant hypertension. So once again, it's a highly selective molecule. It shows reduced risks of sexual side effects as compared to placebo as well as CNS side effects. It has a short half-life, it has no metabolites, it has a tissue distribution in the ratio of 1:1 and has extremely low rates of hyperkalemia, whereby there is a lower incidence of interruption of treatment due to this molecule. So it's very important that what are the side effects of these molecules, and if they are common, how often do we need to discontinue this drug? So key points would be of this particular first half would be individuals with diabetes are tenfold more likely to present with ESRD than those without diabetes. Many patients may not reach ESRD due to premature death from cardiovascular disease. So early stage CKD management is often missed, and if managed appropriately, its progression can be slowed or halted. So despite the RAS blockade, SGLT2 inhibition, patients are at risk of chronic kidney disease progression. Mineralocorticoid receptor overactivation leads to inflammation and fibrosis, and is a potential standpoint at which we can target to reduce the rate of progression of chronic kidney disease. And Finerenone is different from other steroidal mineralocorticoid receptor antagonists and is the only MRA that has been approved in the treatment of type 2 diabetes with CKD. So coming to the second half of the talk, that is what are the cardiorenal benefits of Finerenone across the chronic kidney disease and type 2 diabetes. And I'll be talking about the Fidelity trial, which is the largest trial of type 2 diabetes mellitus patients with chronic kidney disease. So following a successful phase 2 studies, a large phase 3 program was initiated that investigated Finerenone in patients with type 2 diabetes with CKD. So these are the list of phase 2 trials, which are the ARTS trial, which had CKD with low ejection fraction. Then we have the ARTS-DN, which had type 2 diabetes mellitus with CKD, and ARTS heart failure trial with type 2 diabetes mellitus, CKD and reduced ejection fraction. And in all these phase 2 trials, the side effect profile of Finerenone was extremely low as compared to eplerenone or spironolactone. So the phase 3 program, which involved more than 13,000 patients, included the Fidelio diabetic kidney disease trial, which showed that Finerenone reduces the kidney failure and disease progression in patients with type 2 diabetes and CKD, and the Figaro DKD, that Finerenone also has a role in reducing the cardiovascular mortality and morbidity in patients with type 2 diabetes mellitus and CKD. So when we club Figaro and Fidelio together, then we have what is called as the Fidelity trial, and as you can see, all population of patients are very well represented in both the trials. We don't go on to CKD stage 5, that is anyone with an EGFR of less than 15 was not part of this trial. And so we can see from mild to moderate to severe albuminuria, and from stages of CKD 1 to 4, it has roughly representation of all kinds of patients. So at baseline, patients in Fidelity had well-controlled blood pressures and HbA1c. 40% had an albumin creatinine ratio of greater than 30 mg per gram and an EGFR of greater than 60 ml per minute per 1.73 meter square. Eligibility criteria: type 2 diabetes mellitus, CKD on single RAS blockage with a normal serum potassium of less than 4.8. So on an average, if you see this trial, the mean age was 65 years, majority were males. HbA1c was relatively well controlled, 7.7, with most of them having normal blood pressures but high protein creatinine ratio with a mean of 515 mg per gram. The EGFR was more or less around 60. They had large proportion of the patients, 46% had a history of cardiovascular disease and 7.7% had a history of heart failure. And if we see the baseline medications, large number of them were on RAS blockade, were on statins, and some of them had been initiated on SGLT2 inhibitors or GLP-1 receptor agonists for their diabetes. So the results of this trial, I'll be briefly just telling you the highlights. The Finerenone significantly reduced the risk of cardiovascular outcomes by 14% when you compare it with placebo. So the cumulative incidence of cardiovascular death, non-fatal MI, non-fatal stroke and hospitalization to the heart failure was highly favorable in the Finerenone group, with being highly significant for the last column, that is hospitalization for heart failure. Finerenone significantly reduced the risk of greater than equal to 57% fall of EGFR kidney composite outcome by more than 23% when compared to placebo. So again, the time to kidney failure, that is a sustained greater than 57% decrease in EGFR from baseline or renal death, was significantly better and favorable in the Finerenone group. And if you compare the findings versus placebo, so you can see that as early as month 4, there is a significant widening in the two horizontal lines. So there is a significant reduction in albumin creatinine ratio of patients taking Finerenone versus placebo, and this effect is persistent and it goes on for a long period of time, up to 5 years. That is what the duration of the data was, so I am not commenting beyond that. So, however, like its other molecules like RAS inhibitors, or if you talk about SGLT2 inhibitors, there was an initial decrease in EGFR, mean 2 ml per minute per 1.73 meter square was observed in patients on Finerenone, that attenuated over time compared to placebo, and this decrease appeared to be reversible with continuous treatment. So when you start a person on Finerenone versus placebo, you might face a slight rise in creatinine or a fall in EGFR in the initial stages, but from there on, as the progression continues because of its good effects or anti-inflammatory, anti-fibrotic effects. It will ultimately lead to delay in the progression of chronic kidney disease, and the placebo group definitely had a worsened EGFR with time. So again, this is similar to SGLT2 inhibitors or RAS inhibitors. Finerenone had similar adverse effects compared with placebo, with an increased incidence of hyperkalemia, but the clinical impact of this was minimal. So when we compare the adverse effects of Finerenone versus placebo, the percentages are very similar. For acute kidney injury, the systolic blood pressure did fall significantly in the Finerenone group versus the placebo group, and there was no change in HbA1c. So if we see that the maximum difference in mean serum potassium in the two groups was only 0.19 millimole per liter, and the hyperkalemia leading to discontinuation or permanent discontinuation of Finerenone was only 1.7%, which is a relatively low figure. And which are the patients who had a high risk for discontinuation or hyperkalemia? Well, they had a high baseline potassium, they had a lower EGFR, they had a higher urine albumin creatinine ratio, and had a history of beta blocker use as well. So this is the following dosing algorithm that can be used to initiate and maintain the treatment of Finerenone. So broadly, close to the end. So we start Finerenone for the potassium of less than 5. We usually start at a dose of 10 mg once a day. If the EGFR is between 25 to 60, 20 mg once a day. If the EGFR is greater than 60 ml per minute, we monitor the potassium month 4 and there onwards. If the potassium still is below 4.8, we go on to 20 mg once a day. If it is between 5 to 5.5, continue the same dosage. If it's more than 5.5, we will discontinue Finerenone. So Finerenone, this is the largest study up to the date which has been used to investigate Finerenone. Finerenone also showed a significant reduction in cardiovascular events and delaying progression of chronic kidney disease, and Finerenone had similar adverse effects as compared to placebo, which is minimal hyperkalemia, but the clinical impact was minimal. So just coming to the guidelines in the end, that how do we manage patients with type 2 diabetes mellitus and chronic kidney disease. So coming back to this case again, we've added Finerenone, and we've added in a dose of 20 mg once a day because the potassium level is normal and its EGFR is still 61 ml per minute. And now we will see on top of the medications that how the patient actually responds. So it is clearly also important to note, irrespective whether a person is on SGLT2 inhibitors or not, Finerenone independently has an effect in decreasing cardiovascular outcome and kidney composite outcome, whether a patient is on SGLT at baseline or not, and it definitely has a role in reduction of albumin creatinine ratio and renal outcome, irrespective whether the person is on SGLT inhibitor or not. So have a look at the graph where you can see 37% is the combined effect of two drugs. Individually, Finerenone leads to 31% fall in the albumin creatinine ratio. So again, the benefits of SGLT2 inhibitors and ACE inhibitor ARB are over and above the Finerenone benefits. So if you use the two alongside, they have a synergistic effect. If you don't, well, alone also this molecule can be good in reduction of proteinuria and cardiovascular outcome. So this is the 3-pillar management of any patient who now presents with type 2 diabetes mellitus with CKD. Use RAS inhibitors, non-steroidal mineralocorticoid receptor antagonist, and SGLT2 inhibitors. So again, showing that the risk of heart failure and hospitalization with Finerenone is also less as compared to placebo. So whether a person has atherosclerotic cardiovascular disease or not, all kinds of mortality and cardiovascular outcomes actually favor patient with Finerenone. So coming to the slide, that people do have risk of hyperkalemia, but which are the patients in which Finerenone needs to be started? So less than serum potassium 5, avoid Finerenone in an EGFR of less than 25 ml per minute and use with precaution in less than 15 ml per minute. Avoid in people who have hepatic impairment, even moderate hepatic impairment. Avoid in people who are on strong CYP3 or 4 inhibitors or on other potassium sparing diuretics, potassium supplements or other drugs that can lead to hyperkalemia. Though it's a disease modifying anti-proteinuric medication which acts on mineralocorticoid receptor overactivation to delay the progression of chronic kidney disease and has both cardiovascular and renal benefits. So this is the final slide. And these are the 5 fives of Finerenone. So whatever I have discussed is mentioned here. So what are the exclusion criteria for Finerenone? Remember, if a patient is on potassium sparing drugs, avoid. Hepatic impairment, avoid. Adrenal insufficiency, avoid. Leads to hyperkalemia. Strong CYP 3A4 inhibitors, avoid. Pregnancy, lactation, avoid. Inclusion criteria: patient with type 2 diabetes and chronic kidney disease, serum potassium less than 5, age greater than or equal to 18 years, albumin creatinine ratio of greater than 30 mg per gram, and an eGFR of greater than 25 ml per minute. Outcome: decreases end-stage renal disease by 20%, hospitalization due to heart failure by 20%, permanent discontinuation is very low due to hyperkalemia 1.7% only, reduces cardiovascular mortality by 12%, reduces albumin creatinine ratio by 32%. What do we monitor? The monitoring pattern. Monitor the potassium, monitor the eGFR, monitor the creatinine, the blood pressure, and the urine albumin creatinine ratio. Thank you.
Good. Dear friends, I think you must have been reminded of Shankar Mahadevan, breathless songs. सुने होंगे कई सारे गाने. So बिना सांस लिए बस एक ही सांस में. I think it was wonderful. So I wish we have more time for our interaction. Our friends are bubbling with questions. They will have their queries. That will be even more effective. Of course, your slides, your efforts are wonderful. So our next wonderful speaker, Dr. Biplab, wonderful इसलिए मेरे साथ वो बैठे थे, मैंने देखा, is really wonderful. वो भाई बंगाली बोलते हैं, वो हैं भी बंगाली. I was impressed by his personality, the way he was presenting himself. Dr. Biplab Das is Director and Senior Consultant, Neurology and Neurointerventional Neurology. So Narayana Hospital is our host today. Both are from the same hospital. His main interest has been in stroke and neurointervention in stroke also. He has been also working with many other hospitals which we are so closely attached to, like Batra, Vedanta, Fortis Gurgaon. And I found so many of our friends having seen him, interacted, and had referred patients with him also. So I will invite him for his crisp, non-Shankar Mahadevan talk. Sir, keep it smart, slow, and have more time for interaction. Sir, आपको ज़्यादा मजा आएगा. आपको भी हमें. आपके
Good evening, everyone. Thank you for kind introduction. So I will try to be slow and with more of a case discussion. It's not like any presentations over here. And especially I'm thankful all of you in such a rainy season in the evening time. There's so much of traffic and still you come and it's a wonderful gathering. Anyway, so I'm Dr. Biplab. So I'm studying neurology and neurointervention in Narayana Hospital. So I'll just share a few things about what's update about neurointervention. As you know that neurointervention is something where without doing an open surgery, we can reach into the brain, we can reach into the spine and can see some of the abnormal things like some arteries ruptured because of aneurysm, or if there is a clot, we can remove the clot and all these things. So this is our team there in the cath lab. So we handle both the neurology and the neurointerventions as complete neuroscience program. So our core team, Dr. Somya is there, he's a neuroradiologist. Dr. Devashish is also a neurophysician and neurointerventionist. So if you talk about the comprehensive care, that includes neurology, neurosurgery, neurointervention, neurocritical care, neurorehabilitations. This is a very, very critical part of complete comprehensive care. We are proud to say that Narayana is such a hospital where we can look for a quality, affordable and reachable care. So that is one thing which we really say. And one of the most important thing about Narayana Hospital is a stroke ready center. As far as neurointervention is concerned, this is a stroke ready center. Stroke ready center ka matlab hai the center where 24/7, 365 you have a complete care possible for any person who is having a stroke. Whether you talk about clot removal procedure, whether you talk about some surgical procedures, directly coming to a case. So some of you already have seen this case, might be. Interesting case. This is a young gentleman. He was a MNC worker, went for a job. In the office itself, he started developing left side complete paralysis. आपका audio नहीं चल रहा है? Audio को देख लीजिए. So if you look into this video also, you like this look. The left side is not able to move at all. Zero power. Left side completely paralyzed. Suddenly you went to the driving, you went to the office, and suddenly you have weakness on the left side. So other parameters are somewhat closely normal. Young guy, he never had any test done, although he is a very chain smoker. So just a close view, you can see the facial deviation, muh tera hai, and the left side his weakness is there. It's a simple basic test we do when a person suspected stroke comes to the emergency. We see whether the stroke is because of clot or is because of bleeding. It's a very important step to differentiate between these two. It's a simple CT scan will get low. And then if it is not a bleeding, we see how much of the area of the brain we can save. So we do a perfusion study. So this is a perfusion study from where we can make out the area which you can save. So straight away we take these patients after thrombolysis into the cath lab. That's the Neuro cath lab. So if you look closely over here, I think light is there. Yes. From here, the right side there, this is a branch which is completely blocked. So right MCA M1 is occluded. So we reach into the brain, to the groin, and take out the clot. And if you see here, this is the clot which is being removed and complete reclination is achieved. Post-procedure, the miracle is here. The post-procedure, these patients on table started moving left, upper limb and lower limb. And that's something which is really rewarding. You get the enthusiasm to do much better for the next patients. So I'll show you the video again. I think the volume, some issues with the volume. Look at the left side. So he's starting moving left side, leg is starting moving. And this is on table. You can see the someone is pressing the groin also. So on table. This is wonderful. For any physician, for any interventionist, anyway, it's okay. It's okay. Any intervention, this is wonderful. This is what we do. But at the end of the day, this is possible. It's not like the person who has done this procedure, I have done the procedure, I am getting all the credits. It's always a team effort. Stroke treatment is always a team effort. Together we achieve more. It starts from the periphery itself where the patient's awareness. I thank his co-worker who has taken these patients in the hospital in this golden hour. That's very important. Number one. Number two, the ear physician who was there in emergency. So the trial was started, the code brain was activated, and then we started this. Once the code brain is activated, we do all the investigations, all the basic tests very fast, bypassing the normal queue. And that's how it makes a lot of difference. So you all know there are two modalities of treatment in patients with stroke. One is giving the injection that can be given in any of the peripheral centers. The most important thing is do a CT scan, and you can have a consultation with a neurologist, or even you can take a decision based on the CT scan finding. if it's an anomaly, and if it is a, the area of infarct is very less. The usual golden hour is 4.5 hours, but now it is more crossing beyond 4.5 hours also we are doing thrombolysis. And this is artery mobile procedure, mechanical thrombectomy. Okay? So we reach into the brain using through the radial artery or femoral artery, or sometimes directly cavity puncture. Case 2. This is just to show you how young persons are getting stroke. Like decades back, it's something like somebody having a stroke used to think might be 80s, 90s, something like that. It's not, it has dramatically changed, believe me. For me, in my hospital, not only me, all over India and subcontinent, like 40-50% patients are below 40 years. Below 40 years. That's what I said. And this is such a guy. He was referred from other centers. He had a stroke. He had right side complete paralysis. Injection thrombolysis was started from outside. He was referred to our center. And this is post procedure. If you look into this video, the post procedure, look at here. See the day, next day after 24 hours, he started moving the right leg. Yes, it was completely paralyzed. Then I will show you another video. This is a day 7 before discharge. This is again, he has started moving. Wonderful improvement. But look at here, the wrist, still there is a wrist drop is there. But still he has made a lot of improvement. He has complete paralysis right side, not able to speak at all. He was a chartered accountant guy, still he is following with us. He's having wonderful family, having one child. So he's doing a good job. He's continuing his CA. So that means his calculations he is able to do. Maintaining his high functions is still do. But there's mild difficulty in breathing properly. Anyway, so this is to highlight the number of the paradigm which is shifting now. Patients who are having stroke and the role of neurointervention in such patients. Because decades back, somebody having stroke, fine, ho gaya to gaya. So that concept has completely changed. Now, treatment for stroke is so effective, but provided the person comes within the golden hours. More earlier than the best outcome is there. Standing is one of the things which is required for patients who are having high risk for stroke. Standing versus earlier used to do is carotid and arterectomy, very effectively being done by neurosurgeons. It is also done all over the world. But carotid standing over the years has come so much of first preference because it's a non-invasive thing and very safely can be performed in patients who are requiring carotid standing. I'll just show you one cases. This is a gentleman who is having recurrent stroke. So we did an angiography. We found that, can you see how severe is the stenosis? Look at the critical stenosis, just a thread. Critical stenosis. Just a close view again. So we did standing. Just I have not gone through in detail about how the procedure is being done. I am showing you picture pre and post. This is the pre picture and this is the post picture. So you can see that from here, the carotid standing very effectively can be performed. Look at, go for the next case. Another guy, just a few days back. She is a lady, she had been recurrent stroke. Just a thread, even you cannot see properly, this is a thread actually. Right, such a critical, more than 19% I would say. Severe stenosis and you could decanalize completely. This is where now. Look at here, this is here. Moving to the case, next case. This is a 52-year-old gentleman who is having recurrent stroke, blurred visions. And if you look over here, on the left side you can see MRI was performed with this gentleman, and you can see on the left side it was reported that it's completely occluded. So when over the time we found that MRI is not an ideal case to say somebody is having complete occlusion or not, because it is sometimes it's a very severe stenosis, it is being reported as a complete occlusion. So there is a very thread-like thing. We thought that we go for a DSA. यहाँ पे देखिए आपको पूरा complete occlusion में बोला था, but we did a DSA. Once we did a DSA, we found that there is some thread-like things is going on. Look at here. My thread is there, so it's like very severe critical stenosis, and it could happen again. So what I'm saying that carotid standing is possible in a very effective and safe way in patients who is requiring that and patients who are in recurrent stroke because of carotid stenosis. old. Okay, this is just to show you pre and post procedure. Next case. This is a young female. She was actually she's from US. Young female, and you might be knowing that getting a date in US is so difficult. Someone's having headache, to get a date to see a neurologist is like after 6 months you get a date. So she's having recurrent headache and tinnitus. She was evaluated outside, and she came to us also. This is a CT scan just to show you. She was non-confirmatory, non-conclusive. So she came to us with a diagnosis of migraine. So migraine के लिए evaluate किया था, but कुछ नहीं मिला. So then we was evaluated is there any secondary cause. One of the causes which is the IIH, idiopathic intracranial hypertension, which can happen. And in patients who are having IIH, we should always look for transverse sinus sigmoid stenosis. We did a PSA, and if you look closely, this is a stenosis in the sinus. Look at in other view, the significant severe stenosis. So we went into the sinus and measure the pressure difference. Before taking up this patient, we need to check what is the pressure difference between the pre and post stenotic area. And we check the pressure difference with the catheter placing distally and the proximally also. When the pressure difference is significantly different, that is the indication for standing. It's not like all patients who are having stenosis should be taken up for standing. Can you reduce AC like this? I'm shaking actually. So my voice is also getting shaky. Wow, that's so anyway, so this lady, she underwent standing. She came to us and we put a stand for her, and after that her headache and tinnitus are significantly reduced. So it means that all headache are not migraine. We should not be, any patients who are coming with headache should not be like migraine or pain. So we should see some other causes, especially patients who are in obese, recurrent headache, tinnitus, vertigo ho raha hai. Always think of something different, because in sinus, if there is a diabetic lung is there, it will give rise to tinnitus. If there is significant stenosis, this will give rise to headache also, and associated blood lesions can be there. So if you look into the pressure, checking the pressure of CSF pressure also, you can make out from there. So all headaches are not actually migraine. So as I say, stroke more than 70-80% are because of clot, no doubt, but 20% is because of bleed. So among the bleed, one of the causes is like aneurysm rupture. I will show you a few cases of this is SH, subacute hemorrhage, and that's huge advancement over the 4-5 years or a decade. The role of neurointervention in subacute hemorrhage or anywhere in the brain. There's so much of advancement I can say now. Very safely and effectively we can handle all sort of aneurysm now without opening surgery. Either you talk about simple coiling, you talk about stent-assisted coiling, flow diverter, intracircular devices, so much of advancement. I'll just show you a few maybe case. This is an aneurysm. You can say the aneurysm will be a very large dysplastic aneurysm, or it can be multiple aneurysm, or it may be very dysplastic sort of aneurysm or a small aneurysm, blister aneurysm we can say. So any of the aneurysms can rupture, can be life-threatening, and in best of the patient in the world, like up to 50-60% patient in spite of giving best treatment, the mortality happens. Okay? So this is a young female again. She was from Nepal, and if you look at such a large dysplastic aneurysm in the right side of the brain, and this is the MCA. Hopefully I'm having the video. Yeah. So look at here. The whole artery is dysplastic. It's like a tumor. So the options we are very limited now. Either we open surgery where we do the bypass from the proximal part of the MCA and then ECA. So we can do the bypassing so that this aneurysm is bypassed. That's the invasive things. Other than this, you can go is like endovascular way. Endovascular way is putting in flow diverter. As the name says, flow diversion hoga. Flow diverter. So yeah, the flow diverter is placed just after 7 days before discharge. This lady, she will be going back to Nepal. She might not be able to fly back and coming for a normal follow-up. Usually we do after 3 months. So just lets me have a check how the stand is doing, how it's doing. So this is just after 7 days. If you remember, I'll show you again. This is the aneurysm. This was the aneurysm 7 days back. We have placed a flow diverter. And this is after the 7 days. The aneurysm is completely gone. This is such a reconstruction of the artery. This is possible because of the advancement of the hardware which is available now. That is how it is working. Similarly, there are different other devices which is available, like intracellular devices. Aneurysm is there. You are putting a device within the aneurysm itself. Spinal area, very different. Look at this 8-month child from Assam. He was referred because of lower limb weakness. So then any person who is in lower limb weakness, we will see is there any spinal area is there or not. Look for the phloboid. Typical term which is being used is the phloboid. Okay. So he had a phloboid, and then that's why he was referred to us. So we did an DSM just to check where is the fistula, what is the location. If you look here, you can see this is the large aneurysm is there, and there is a dural fistula which is happening. Spinal dural fistula. We look into the feeders. Feeders comes in, because we need to seal that one. I'll jump few slides here because of time. So this is, you can see the large aneurysm, and we did sealing. We did coil embolization also, and glue. This is just after 3 weeks. Just after 3 weeks. Started moving legs. Okay, where there is a condition, not able to move at all because of edema and all these things. This is after 3 weeks time. This is after 6 weeks time. Standing, and now he is doing one. So the diagnosis and early treatment makes lots of difference. AVM embolization. So AVM can give rise to bleeding the brain. Doing an embolization is a very, very effective way to do these procedures. Tumor embolization, neurosurgeons, before going for surgery to reduce the bleeding and other leaks. High vascular tumors, we do embolization first to reduce the blood supply. Give a nice bed for their going for surgery. This you can see such a high vascular tumor. We did embolization, and then post embolization you can see completely it is gone. Emergency care. Neurointervention is huge importance in emergency. We have been seeing patients where surgeons, we talk about neurosurgeons or orthopedics, or when incidentally happens, it can happen to anybody. Like you are doing some surgery, the vertebral artery is being dissected. So the options which you have to take this patient urgently and fill this one. So here also you can see during the surgery, this is the vertebral artery. It's like a floodgate is open now. Whole blood, the patient was rushed to us, hypotension, severe hypertension, then we have to go there and seal this one. So this is where there's a huge importance of neurointerventions, the very, very effective way of saving life possible. I think I will stop over here. Thank you very much for your kind attention. Okay. Also, I would like to invite you all. We are organizing a master class in stroke neurology. If someone is in interest, although it's a limited seats, so you can please directly contact me. And also, we are organizing a national stroke and neurovascular conference in Guwahati, of course. This will be happening in third week of September, and we will also invite you all for the same. Thank you very much.
Dear friends, you must agree, Dr. Kanpur sir, Dr. Kanpur, you must agree.
Please come here. Please come.
Another mesmerizing talk.
Sir, please come here.
One was Shankar Mahadevan versus the fiction and the science fiction or whatever you can say, something we can only imagine, we have never seen. So we will now open the house for talk after my 3 brief questions to. I just wanted to know.
You have listened in stunned silence, both the speakers. मुझे सिर्फ 20 मिनट आपकी वो चाहिए, अटेंशन चाहिए, डॉक्टर चक्रवर्ती, डॉक्टर शरद. अगर आप लोग मतलब यू बीन सो डिसेंट ओवर सो मेनी मंथ्स, मुझे सिर्फ अगले 20 मिनट चाहिए आप लोगों से, उससे ज़्यादा कुछ नहीं चाहिए, ठीक है? और बोलना नहीं बीच में, इस 20 मिनट में बोलना नहीं बिल्कुल भी. बढ़िया सवाल पूछो ताकि हमारे जो स्पॉन्सर्स हैं वो अगली मीटिंग मुझे दें. आपको पता है मेरा उद्देश्य सिर्फ एक है, मुझे अगली मीटिंग लेनी है, ठीक है? और वो आपके सारे लेनी है, ठीक है ना। तो अगर आप लोग सहयोग करोगे तो हमें अगली मीटिंग मिलेगी। अच्छे अच्छे सवाल पूछो, ठीक है, और बढ़िया सवाल पूछो ताकि स्पॉन्सर्स को, स्पीकर्स को ये लगे कि आपने उनका लेक्चर सुना, ध्यान से सुना है। और डॉक्टर एम एल कालरा सर के 3 सवाल हैं, पहले वो सुनो।
Dr. Sudeep sir, wonderful talk. Of course, it was a very high-speed recording.
Thank you.
So we have 2 main parameters, like albuminuria is one, and the other is EGFR, to decide how the kidney is being damaged. So, like we use statins in all diabetics, even if there is no damage done, we are doing for prevention. So, is this molecule, Finerenone, to be used even if there is no damage done, or we have to wait for the damage to be done and then we start?
Sir, the pathophysiology of the molecule is such that it leads to anti-inflammatory and anti-fibrotic effects, and albuminuria is the earliest in that stage of pathophysiology. So starting it as a prophylactic is not the correct way, because it is a new molecule, has been introduced, it's a costly molecule. It has been introduced to delay the progression, and the point of action should be the point at which the damage, we have documented damage that has happened in the form of proteinuria or albuminuria, which is the earliest point. So at this moment of time, no trial or no literature suggests prophylactic use of this drug. So yes, we started at an early stage when we see that albuminuria is there and people want to go for tried and tested molecules such as RAS inhibitors prior to starting this molecule. So in spite of starting RAS inhibitors and maybe SGLT2 inhibitors, if we fail or if there is a contraindication to either of the two, we can start this individually also as the first line in albuminuria.
It may be question A1. Correlated to that we say diabetes is CVD equivalent. So when diabetes is established, a person is having diabetes for quite some time, 4 or 5 years. So we presume that some damage to be done to the cardiovascular system. We may not be able to quantify. So you still say it is to be waited until the damage is established.
So again, the trial which I showed, it showed all cause of cardiac morbidity, including hospitalization due to heart failure, LVH, and this thing. But unless we have those side effects or some documented end organ damage, starting it prophylactically again for such a costly molecule will be a difficult thing to do.
It's a reserve molecule.
Correct.
Number 2, sir. If a person has single kidney, do we have any special consideration, or do we still have same parameter, albumin this and EGFR this, potassium this, or we have slight soft corner?
So you are asking with respect to initiation of the drug only,
Yeah.
with a single kidney. So a person with a single kidney will have a higher risk of high potassium or side effects because it is a single kidney. So the guidelines for starting or discontinuation remain the same. But again, if it is a single kidney, I would like to start with 10 mg once a day, which is a low dose, even if the person has a normal GFR. And then if it remains below 5, then I can think about introducing 20 mg or twice the dose.
My last question is, sir, like we have a fibroscan for liver. Do we have a fibroscan for kidneys also, or we are still
EGFR.
EGFR is the only thing?
So sir, when we talk about the imaging test, obviously ultrasound is the one with which we screen the size of the kidney. And if we want to go into the functional, even though this is not a very accurate estimation, but DTPA scan is what we go with to estimate the right kidney, left kidney and the combined function of them together. So in terms of fibroscan equivalent, I will say ultrasound would be better option. But gold standard again, if you want to judge the degree of damage, the percentage of damage, and whether there is an acute active damage happening, biopsy is the only way to actually find out.
Dr. Sachdev, Dr. Amish Mora, an eminent oncologist, moving away from auxiliary sarcomas, leukomas, and everything else, he is on to some nephrology.
Thank you. First of all, my congratulations to Dr. Das. Amazing cases. The videos what you have shown, it gives goosebumps that those are the vital hours where we should send patients to you. My question to you, sir. First of all, I hope Bayer has not sponsored this event. Okay, perfect. So then I can ask my questions. New England Journal of Medicine, Finerenone trial. There are 3 points which I didn't like this drug, and I asked 4 nephrologists and 2 cardiologists. They said this is a weaker drug. 3 points. One, SGLT2 inhibitors, only 6.7% of patients had that. There is no way you can put on the forest plot chart SGLT2 inhibitors. This was not a right way to put a forest plot chart. Second, exclusion criteria was potassium more than 4.6. 4.8. And you have an algorithm of 5 से ज़्यादा potassium हो तो कितना dose देना है, कितना करना है. Again, this was not the right thing. Third, if you see, only the hospitalization was the only statistically significant. Rest all hazard ratio of 0.82, 0.86, which in oncology field we take anything less than 0.75 is not significant. I don't know about nephrology, but I would like to have an honest opinion from you. Is this just a one more weaker additional drug, or are we playing too much with this?
Sir, it's a good question, but the armamentarium for a nephrologist to decrease protein leakage in a patient with diabetic nephropathy is very limited. We have RAS inhibitors, and we all know that when we start ACE inhibitors, ARB, there is a 25% rise in the serum creatinine. When you ask any person in CKD, he is more concerned about creatinine than albuminuria, even though the more concerning factor is albuminuria, because even albuminuria of more than 30 mg per gram, in my experience, even 300 mg per gram, more than that can significantly cause a deterioration of creatinine. So you give the person ACRBs, the person you cannot go to a higher dose because of its limitations, then what other option do you have? You have SGLT2 inhibitors. So let me tell you, in my experience, when I treat diabetic nephropathy in females, you will see 30 to 50% are above the age of, let's say, 40-45, postmenopausal, and they have a very high incidence and risk and prevalence of UTI. So SGLT2 inhibitors, there are also other side effects in males also. I would rate the anti-proteinuric ability of this drug higher as a nephrologist rather than, cardiovascular benefit or delaying the progression of chronic kidney disease. So I would say first line is RAS inhibitors, second line SGLT2 inhibitors. SGLT2 inhibitors are now even used for non-diabetics, and that is a good thing. This drug is in its trial phase for non-diabetics, other causes of proteinuria. So for me, I have another option, and let me tell you, I have introduced it in lots of patients. Clinically, it's very difficult to judge clinical significance or not, but yes, the protein creatinine ratio of majority, I would say 8 out of 10 or maybe 85% out of 100 has come down after the use of this drug without, in a low dose, causing hyperkalemia. But yes, in certain patients who are already on concomitant RAS inhibitors, then we know that potassium is a problem. So I take as a liberal of 5.5, and those who are also in CKD 3B and CKD 4, I don't start more than 10 mg once a day. 15 से नीचे GFR में शुरू करते ही नहीं. तो ऑप्शंस आप देखिए कितने हैं नेफ्रोलॉजिस्ट के पास, तो उस हिसाब से मेरे लिए एक अच्छी दवाई है. स्टैटिन्स है, स्टैटिन से तो डेफिनेटली ज़्यादा स्ट्रॉन्ग है, ये हमें पता है. एंटीऑक्सीडेंट से स्ट्रॉन्ग है, फिश ऑयल से ज़्यादा स्ट्रॉन्ग है. तो मतलब rather than starting these drugs, statins के अपने साइड इफेक्ट्स होते हैं, बहुत से पेशेंट्स को होते हैं. I would feel that after RAS inhibitors, it is an option. And personally speaking,
RAS and SGLT2 both, or after RAS?
Depends. SGLT2, see, it is difficult because certain people don't want SGLT2 inhibitors after reading the side effects. The certain genital tract infections are also there. So for me, it is a good option and it is a safer option. So I would say that it's still in its nascent phase and we are using it. But for us, it is a good way of judging it.
Very good answering and good questions, Dr. Anish, by the way. I wanted to ask you some basic questions. Dr. Anish also mentioned about it, and Dr. M L Kalra sir also mentioned about it, the SGLT2 inhibitors. For us who are treating the majority of diabetic patients, and we have patients with proteinuria, we are putting them on SGLT2 inhibitors. most of our patients are either on ACE or ARB. And some of our patients are also already on MRI. Now during that journey, sir, where should we consider taking out, let's say, aldactone or eplerenone and substituting them with Finerenone?
So, sir, this is the only molecule in type 2 diabetes mellitus with nephropathy which has been indicated for treatment of proteinuria. Nowhere eplerenone and spironolactone is used for that indication. They are usually used either for resistant hypertension or patients with heart failure with reduced ejection fraction. So the indication of using the two drugs is different. That is mainly for cardiovascular morbidity and mortality. That is spironolactone and aldactone. That is mainly for cardiovascular point of view, spironolactone, aldactone, and more concentrating on the hypertensive aspect. In this case, we go on to Finerenone to reduce the protein leakage. If we feel that one of the highest albuminuria or proteinuria is not coming down with RAS inhibitors and SGLT2 inhibitors, then the correct point, if the BPs are well controlled and you feel that the cardiovascular morbidity or mortality, you have other drugs like beta blockers that you are giving and ACE/ARB you are giving, then it is better to introduce this drug and withdraw those. So the focus is different.
Right. As you mentioned, and I understood from the talk, serum potassium is the bottom line when you are using Finerenone, and it has to be monitored. Although you said many other things, EGFR and etc. etc. But for me as a practitioner, I understood that serum potassium stands out as one single most important thing that has to be monitored with Finerenone. Sir, how frequently do you monitor serum potassium when you are using Finerenone? Number one. Number two, does that frequency increase if you are concurrently using SGLT2 inhibitors?
So, sir, this is a good question, but again it depends on the stage of chronic kidney disease. So if a person with a normal AFR is presenting with this, then I will monitor probably one after initiating the drug, maybe 2 weeks after that, then after a month, and then can be done at 3 monthly intervals. However, if we go on to CKD stage 3, CKD stage 4, then this frequency would obviously shrink. So at least monthly in CKD 3 and CKD 4, maybe even monthly is minimal. I will definitely monitor per month, but if the patient has had a past history of hyperkalemia, then I would definitely go on to a lower dose if on full dose, and then maybe monitor even more frequently till I have stable values, maybe 3 stable values at maybe 2 or 3 weekly intervals.
Sir, you also mentioned that a lot of our people with CKD are using diuretics, and some of them are potassium sparing diuretics. It has been repeatedly told to us that there has never been any clinical mortality benefits with diuretics. We have been trial after trial. So when we are using Finerenone, what do you do to the diuretics? Can we just do away with them or reduce their dose, or maybe how do you optimize the diuretics when you are using Finerenone?
So, sir, diuretics have a very, specific indication of usage in chronic kidney disease. When I talk about group diuretics, maybe Ditor or Lasix, the only indication is that the patient has edema or fluid overload, which comes in, patients usually in CKD stage 5 or maybe 4, our patient has hypoalbuminemia. So only to reduce pedal edema or fluid overload I use. Thiazide group of diuretics are used as an antihypertensive. So the function, this molecule causes a very mild decrease in blood pressure. So it is not being used for that purpose. So for me, the benefit would mainly be albuminuria, albumin-creatinine ratio, and the proteinuria and diabetics. So the focus again is a different focus of using this molecule.
Dr. Makkad, just a minute, sir. Please come here. Please, sir, 1 minute aa jao. Sir, aa jao na 1 minute. Let's welcome Dr. B. M. Makkad, sir.
And just wanted to say
and our own Dr. Surjodip Sen Gupta. Sen, aa jao, 1 minute. Sir,
I just wanted to say hi to everybody and have a good time. Thank you.
सर यहाँ ये कह रहे हैं दिल की महफिल सजिए चले आइए, आपकी बस कमी है चले आइए, कोई सवाल आप भी पूछ लीजिए।
गली छोड़ा है
sir, thank you.
मगर बस वाली कहानी थोड़ा चल रही है।
Dr. S. Gupta is going to chair the session by Dr. T.S. Clare on 14th of August.
सर ने फांस के रखा हुआ है जो भी है ठीक है थैंक यू
अगले बार आप ट्रांसफर को मत रखिएगा अपना
He is moderating the session.
उसके बाद
See, the only way of keeping Singh Gupta not facing us is making him the moderator of the CME. I'll do that. Thank you very much.
अब मेरा क्वेश्चन
It's on me. Thank you, Dr. Pankaj sir. I'm sure you would be satisfied, but if you could have a drink, maybe 30 ml with us. All right. I'll leave you. Sir, my last question to you. How much does kidney transplant cost in your sector?
So sir, the pre-transplant workup of donor and recipient, the OPD investigations, clearances cost around 1.5 lakhs. And at the time of admission, both for the donor and recipient.
Sir, let's bring it to the total.
Total would be around 8.5 lakhs for everything, excluding dialysis on OPD basis.
Sir, what is the maintenance cost?
Maintenance cost post-transplant.
For the suppression.
So sir, immediately post-transplant, I would say around 20,000 for the first 3 months. Coming down to 15 to 20,000 from 3 to 6 months, and 6 to 12 months 15,000, and after 1 year around 10,000.
Sir, एक साल के अंदर 15 लाख, including renal transplant.
सोचना पड़ेगा सर, मतलब 7-8 लाख
15 लाख के अंदर हो जाएगा. 15 लाख के अंदर हो जाएगा.
डोनर अपना चाहिए.
Right.
डोनर रिश्तेदारी में भी चाहिए.
Sir, मुझे सिर्फ 2 सवाल. Before I know, I will come to you, sir. I will come to you, and I must compliment all of you guys to maintain silence. 10 मिनट हो गए, बस 10 मिनट silence और चाहिए, and I'll give you a wonderful CME or 14. Believe me, wonderful CME or 14. आपसे सवाल पूछवाऊँ रहता है, आ रहा हूँ आप. 2 सवाल डॉक्टर बिप्लब से तो पूछ लो सर.
पहले इनका
दुआओं सर दुआओं में हो गया सर.
पहले नहीं इसका.
अरे नहीं सर, मुझे तो पूछ दीजिए ना सवाल. दुआओं में मांगा सर, दुआओं में. सर डॉक्टर बिप्लब, मैं आपसे एक चीज पूछूंगा सर. You gave wonderful examples of aneurysms and interventions. Sir, I have a special interest in posterior circulation stroke.
Right, sir.
Sir, what is your approach to posterior circulation strokes?
Okay, so all patients of posterior circulation stroke, first to evaluate is a cardiological cause, etiology, because we feel other than atherosclerotic disease, it is a cardiac disease like atrial fibrillations, things which causes more of a posterior circulation stroke, number 1. Number 2, then you look for vertebrovascular junction atherosclerotic disease. From vertebrovascular atherosclerotic disease can give rise to a same thing. Number 3 is the vertebral artery stenosis from at the origin, जहाँ पे origin होता है वहाँ पे. So these are 3 things where we should check. Number 1, this is as the etiology of stroke. Number 2, treatment. Treatment, if you look in any patients for having TIA or a stroke, the dual antiplatelets to be given for 3 months to 6 months. So there is a different trials which is there. So you can start your antiplatelets, but not in AF of course. If it's a non-valvular AF, we are going for NOAC, newer oral anticoagulants. Yes, sir.
Sir, my second question is the last question.
Yeah.
Sir, what is your approach to vertebral artery dissection causing posterior circulation stroke?
Wonderful, very, very important questions. We very frequently, honestly, see young guys coming with stroke. Young guys, any young persons like Khatta Khatta, Salman Khan, आके stroke होते हुए बहुत देखा है मैंने. उसमें the most important thing they do is they go to the gym, suddenly take lots of weight, they have a dissection here. I have seen lots of patients, not only me. I think Dr. Bhaskar is there behind. So, Bhaskar was there. Yeah. So we see lots of patients who are like bodybuilders. They suddenly go to the gym, take weights, and they have a dissection. They come with a stroke. That's number 1. Number 2, the cause of dissection is like आजकल पार्लर तो मिलते ही हैं, स्पा में जाते हैं, suddenly जाती movements. Sudden जाती movements can give rise to dissection. Number 3, the players who go for taekwondo and all these things, sudden jati movements give rise to dissection. Number 4 is because of arteriopathy, non-vascular, non-atherosclerotic arteriopathy can give rise to dissection. So if this dissection causes a stroke, which can definitely cause, what is the treatment? Number 1 treatment is, earlier it used to be like only anticoagulations. Means you have to give laxants or you have to give your oral anticoagulation, that is also possible. But the data now say that there are 2 ways we need to see. If it is a stroke and also causing obstruction in the flow to the brain artery, then you have to do a stenting. Dissection without obstruction is not an indication for any stenting. Number 1. We are not doing stenting, then what we are doing? We are doing an anticoagulation or antiplatelet. How much antiplatelet? Do an antiplatelet. How many months? Usually 3 months. Usually 3 months. But they dissolve automatically, over the times. That's how.
सर एक मिनट सर मैं आपसे ये पूछ रहा था कि आपने वर्टिब्रल आर्टरी डिफरेंशियल के केसेस में कितने स्टेंटिंग किए हैं?
Over the decade, it might be 1 or 2.
So it's rare.
It's not individual. We find that dissection हुआ है, but उनका flow limitation नहीं हुआ. If it's not flow limiting, you need not to do any stenting.
Right. And the investigation to decide is DSA.
That's the best investigation.
Understand I correctly?
Absolutely, sir.
Right, sir. Thank you. Thank you so much, sir. I will come to Dr. Podar, sir, and I will come to everyone.
So, I think Dr. Kalra mentioned 2 indicators of renal dysfunction, creatinine and EGFR. I think urinary albumin-creatinine ratio should also be included. That's a very good parameter that I have heard. And then now question to our nephrologist friends. Say, Finerenone is a very good drug, but you are not giving to patients with high potassium, maybe 5+. So why it, because considering the advantage of Finerenone in renal or cardiology field, why it cannot be given to high potassium patients with potassium lowering agents? Like.
So sir, the criteria of 5 is for initiation of the drug. Once the drug has been initiated and the serum potassium remains below 5.5, you continue the drug. Once it is above 5.5, then you discontinue. The dosage from 10 to 20, one will not do if it is between 5 to 5.5. So if I am on 10 mg once a day and it is 5.3, 5.4, 5.2, I will keep it on the same dosage. The side effects of hyperkalemia in a patient with CKD who has a high creatinine, the heart tends to be more sensitive to potassium changes, sudden potassium changes, both hypo and hyperkalemia. So that is why going beyond 5.5 for us is a little bit risky, especially at a higher creatinine.
No, I am saying the potassium chelating agents. Potassium level will come down, so more patients will be benefited with this drug.
Chelating agents, you become tolerant to them after 3 to 5 days. So what can you do after 5 days? You cannot give this drug. So you can only give it for a limited time.
And one question, just a comment, Dr. Biplab. So before many of our general physicians, it's just a general question, before when they see a patient of stroke, before CT scan they should not give aspirin unless you rule out hemorrhage. So without considering that most of the stroke are due to infarction, but you must rule out bleeding before giving any antiplatelet. Is it right?
Right.
So even aspirin should not be given. Plain CT can be done immediately, I think anywhere.
Your point is very well taken. I mean, like any patients who are having weakness or paralysis, we should not give aspirin because it can be 20% can be because of bleeding. It's not like heart. If heart attack हुआ तो we give aspirin. It's not like that. Very important point, sir. Thank
Dr.
you.
Biplab, the only
I would say
the only person who actually deserves to ask a question is Dr. Bhaskar, who is DM Neuro.
Yeah,
And
I was searching you actually.
one of our prime members. He will ask you a question.
Yeah, hi, Bhaskar, please.
Hi sir, very nice talk sir.
Thank you.
सर वो जो आपने केसेस बताया मैं एक सर टॉपिक नहीं था और बहुत सारे केसेस ना मेरे अपने पर्सनल एक्सपीरियंस में मैंने देखे हैं जैसे the case which you are talking about about the vertebral artery dissection. So I had one patient myself, sir महाजन गली का ही स्टाफ था वो. He had a carotid artery dissection. We are planning for stenting, but on serial MRIs we could not document any flow limitation, so we just kept it.
Right.
So I do not have any question basically, I have just comments. So carotid artery dissection, just manage with anticoagulation and with rehabilitation, physiotherapy, his weakness is also improved.
Yeah, exactly. Same thing, Dr. Johanna, you have also had. So the dissections, it's like if it is not flow limiting, as you already mentioned, we need not to go for standing. It's only the flow limitations which is happening. Then only we go for standing. Otherwise, it's medical management. It's very nicely managed.
Sir, another young girl diagnosed IH. She was almost going to be blind.
Yes.
We did the CSF manometry. It was like 30 centimeters.
Very high. Yes.
So we tried medical management, bed reduction, and everything failed. So we went for TP shunt.
Right.
But again, the problem with TP shunt is that we cannot regulate the flow. So she ultimately developed subdural hemorrhage also, some because of the poor drainage. And that was lost to follow up.
Right. So in IH patients, we have seen like doing optic nerve fenestrations as we used to do, but now it's not so frequent. If it's like eye vision's compromised very much, you can go for optic nerve fenestration followed by shunting. वही करता है. BGI चंडीगढ़ में बहुत लोग करते हैं, पर यहाँ पे last time we were searching for someone, it is not frequently done.
Before I come to Dr. Tulsi sir, I would request Dr. Ranjit Chakravarti ma'am to ask questions. Dr. Amish, thank you so much. We feel honored by your presence.
Very nice talk. I have a question for Dr. Biplab. Dr. You said that we are seeing around 50% cases in younger generation, 40 years, less than 40 years. The first case you discussed, you said he had no other complication. He was only a smoker, but he had a clot. So what are the reasons? Like we have our children, our son-in-laws and all. So what precautions do they need to take if there is no cause?
Right. So if you look into the last over the decades, and being an honest feeling is that usual risk factor which is there, like diabetes, hypertension, dyslipidemia, all these are usual factors for cardiac and brain everywhere. I feel over the years, pollution, stress, smoking, sedentary lifestyle, not going for any physical activity, high fat diet, fast food diet, this is the common factor which is causing actually this problem. So this guy was a chain smoker. So I feel that sedentary lifestyle, pollution and stress is one of the most important thing I find it's over the years. This is my experience and the data are coming much and much more. Everywhere it's so much of a stress, like everybody wants more work. You work anywhere, in the hospital, you talk about any young chap now, there's so much of a stress, not having sleeping, doing all the time, laptop, no physical activity. Look at that. I mean, it's because of that.
But these things would cause spasm or would they cause clots also? If the lipid profile is normal, then why do we have clots in these? Aneurysm is one reason for young persons.
Right.
But what about clots in young persons with normal blood profile?
So the normal blood profile we say is not only the lipid profile is a normal blood profile. So we are not looking into the blood thickness. There are no actual parameter to say that some patients the blood is more thicker in terms of viscosity. If you look into this, some patients who are having like we see patients who are very much smoker, but is still not having atherosclerotic disease. But these patients are being very predisposed to forming clot formation. Right? We feel over the time that there's a different way of working there, whether it's because of viscosity or hypercoagulable state or something, vasculitis, non-atherosclerotic vasculopathy. There might be some other way. It's very hard to say that but they definitely contribute to this.
So in personal disease, you have seen mostly working in stressful positions.
This is contributing factors. Thank you, ma'am.
Excellent, Dr. Rajni ma'am. Some wonderful questioning. Sir, please come. We have a new member. Sir will introduce himself. Just for a minute.
I am Dr. H.S. Yadav. I am from Bulana Azad, 1973 batch. I am a